It's a pleasure to be here this morning, and Katie, thank you for energizing the room, and hopefully I'm going to carry that through until our break. I always enjoy talking about this new quality measure, drug regimen review conducted with follow-up for identified issues and how to code the new drug data elements that have been added to Section N of the IRF-PAI. We first started doing the IRF training back in December of 2017, and since that time we have learned so much about from all of you in terms of the questions that you have submitted to us. And so hopefully each time I give this, I learn something new, and hopefully I will impart some new information that's going to help you code the data elements and have a great understanding of this quality measure. As you know, this measure is important and critical to the care of post-acute care patients, as potential and actual patient medication errors are prevalent among post-acute care settings and often occur during transitions in care. As we know, medication errors can lead to medication-related adverse reactions, emergency department visits, rehospitalization, and affects the patient's health, safety, and quality of life. A 2014 Officer of Inspector General report found that 10% of Medicare patients in IRFs experienced adverse events, with most of those events being medication-related. Over 45% of the adverse events and temporary harm events were clearly or likely preventable. Medication errors in 1/5 of adverse drug events occur during transitions between settings, including admission to or discharge from a hospital to home or a PAC setting, or transfer between hospitals. The drug regimen review quality measure is intended to improve patient safety and in IRF patients by identifying and addressing potential actual clinically significant medication issues at the time of patient admission and throughout the patient's stay. The next two slides show the acronyms that will be used throughout the presentation and are familiar to all of you. At the completion of this presentation, you are going to state and understand the intent of Section N. You are going to be able to articulate the purpose of the new items and the coding options and how to accurately code the data items. And we're also going to you'll have the opportunity to apply coding instructions to accurately code clinical scenarios. And later tomorrow, you have a case study. And last, you will be able to describe the drug regimen review quality measure. The drug regimen review conducted with follow-up for identified issues post-acute care, inpatient rehab facility quality reporting is an assessment-based cross-setting QM adopted to meet the requirements of the Improving Medicare Post-Acute Care Transformation Act domain of medication reconciliation. The drug regimen review quality measure asks the provider to complete an individual assessment of the patient to determine if there are any problems or issues associated with the patient's medications that need to be addressed in a timely manner before they become worse. The emphasis in completing the drug regimen review data elements and this quality measure is on timely intervention and follow-up with the individual patient's medication issue when it is identified. And as you probably know, the home health agencies introduced or implemented this measure in January of 2010. The long-term acute care hospitals we implemented in July of 2018, and skilled nursing facilities and IRF, as you know, implemented this measure and this section in October. This slide shows the two admission assessment data elements, N2001 drug regimen review and N2003 medication follow-up. This slide shows the one discharge assessment data item, medication intervention, and the responses, and we'll be going into all three of these data elements in detail. Next, we're going to go through a series of definitions. A drug regimen review includes medication reconciliation, which, as you all know, is a review of all medications a patient is currently using, and a review of the drug regimen to identify and, if possible, prevent potentially clinically significant medication adverse consequences. So we often are asked what medications are included for the drug regimen review. The drug regimen review includes all medications, and so that means prescribed and over-the-counter, including nutritional supplements, vitamins, homeopathic, and herbal products, administered by any route. And the DRR also includes total parenteral nutrition and oxygen therapy. A clinically significant medication is our next definition, and this is a potential or actual issue that in the clinician's professional judgment warrants physician communication and completion of prescribed recommended actions by midnight of the next calendar day at the latest. And what I'd like to emphasize here is that what CMS is asking clinicians to do when you are assessing your patients who you know and you're taking care of, was there an issue or a situation when there was a problem related to a medication? And did you, at that time, address that issue? CMS uses the term pushing the needle, meaning providers are actively addressing problems before they become worse. I also want to emphasize that what's really important in coding these data elements and understanding this measure is that you are constantly using your clinical judgment to assess your, as I said, your individual patient. So for instance, what might be a significant medication issue for one patient might not be a significant medication issue for another. So there's no constant or one-size-fits-all, for lack of a better term. We have to look at patients on an individual basis and look at what's going on with them in total. Examples of potential or actual clinically significant medication issues are included on this slide, and they include drug interactions such as serious drug-drug, drug-food, and drug-disease interactions. Duplicate therapy, for example, a generic name and a brand name equivalent drug are co-prescribed. Those of us that are nurses or administer medications, we all know the 5 rights. So, you're looking for, was it the wrong patient, wrong dose, wrong time, wrong route, etc. The medication dose, frequency, route, or duration are not consistent with the patient's condition, manufacturer's instructions, or applicable standards of practice. It might be an omission, drugs missing from a prescribed regimen. It might be non-adherence, and that might be either purposeful or accidental. Other examples include use of a medication without evidence of adequate indication for the use, or the presence of a medical condition that may warrant medical therapy. For instance, the patient has hypertension and it does not have an antihypertensive prescribed. I've observed since that time in December of 2017 when we did the first training that one of the challenges that providers are having is determining whether or not a clinical situation they encounter regarding a medication is a potential or actual clinically significant medication issue that meets the intent of the quality measure. I'd like to emphasize that any of the aforementioned examples, drug interactions, duplicate therapy, etc., must reach a level of clinical significance that warrants notifying the physician or physician designee for medical orders or recommendations by midnight of the next calendar day at the latest. Determining if very timely communication and action is needed is key in determining whether the issue is a potential clinically significant medication issue. Any circumstance that does not require this immediate attention is not considered a potential or actual clinically significant medication issue for the purpose of the drug regimen review items. The next definition I'd like to review is two-way communication. Two-way communication is essential for completing the drug regimen review data elements accurately. Two-way communication means communication to the physician to convey an identified potential or actual clinically significant medication issue and a response from the physician to convey prescribed recommended actions in response to the medication issue. In order to meet the requirements of the measure, you need to communicate and convey the information to the physician, and you need to have received a response from the physician so that you can address the issues. This is two-way communication. Two-way communication can take many forms, as you can see on the slide. It can be in person, by telephone, voicemail, electronic means, fax, and any other means that appropriately conveys the message of the patient's status. The next question that we often receive is, how is a physician designee defined? The role of the physician designee or non-physician practitioner is defined by federal and state licensure regulations. And so I would recommend that you refer to your regulations to determine which clinicians are licensed to act as physician designees. The next definition is, what do we mean by medication follow-up? Medication follow-up is the process of contacting the physician to communicate an identified medication issue and completing all physician-prescribed or recommended actions by midnight of the next calendar day at the latest. Next, we'll go through the coding guidance and some practice clinical scenarios. In order to code the drug regimen review items, you are going to need to refer to and review a number of the patient's medical record sources for this information. And so where are you going to find this information? You have a variety of areas where you can review documentation. It would be medical records received from facilities where the patient maybe received health care, the patient's most recent history and physical, transfer documents, discharge summaries, medication lists or records, clinical progress notes, or other resources as available. In addition to medical record sources, discussions with acute care hospital staff or other staff or clinicians responsible for completing the drug regimen review. Also, the patient and the patient's family may supplement or clarify information gleaned from the from the president's medical record. Another point to emphasize, and it comes from a question that we do receive, is about documentation and what kind of documentation do I need to have for completing the data elements. And so this slide just emphasizes that the information needed to code the item should be consistent with information recorded in the patient's medical records. The drug regimen review process is a multidisciplinary team review of the patient's medications. And as we know, the Centers for Medicare and Medicaid Services does not provide guidance on who can or cannot code the drug regimen review items. But each of your facilities, you're well versed in what your patient population is, what the characteristics of your patient population. You determine your own policies and procedures for who can complete assessments, how do you do your documentation to meet the intent of the measure and accurately code the data elements. And also, as I've indicated, you would also consult with federal and state policies and your facility policy and procedures to determine which IRF staff members may complete a drug regimen review. And another question we often receive is, does it have to be a pharmacist who completes the drug regimen review? And the answer to this is no. Who completes the drug regimen review, as indicated on the previous slide, is contingent upon your facilities, policies, and procedures, and applicable federal and state policies, and your unique patient population. This slide just summarizes the three data elements, the admission and discharge elements, and I'll just review them. N2001 identifies if a drug regimen review was conducted upon admission and if the clinician identified any potential or actual clinically significant medication issues. N2003, also on the admission assessment, identifies if the facility contacted a physician or physician designee and completed all physician or physician designee prescribed recommended actions by midnight of the next calendar day in response to all potential or actual clinically significant medication issues identified upon admission. And 2005, which is the one discharge assessment item, identifies if the facility contacted a physician or physician designee and completed all physician or physician designee prescribed recommended actions by midnight of the next calendar day each time potential or actual clinically significant medication issues were identified throughout the stay. And I will repeat that several times through the remainder of the presentation. We are talking about admission through discharge. Okay, now we'll turn to a description of the data element for the drug regimen review. As I previously just reviewed, there are two admission assessment data items to complete on the IRF-PAI. We've gone over what N2001 identifies, and this is what the assessment it looks like on the IRF-PAI and the three choices that you have. So you have 0, no issues found during review, 1, yes, issues found during review, and 9, non-applicable, patient is not taking any medications. This slide shows the steps for assessment so that you can accurately complete N2001. So you're going to complete a drug regimen review upon admission or as close to the actual time of admission as possible to identify any clinically significant medication issues, and you are going to review the medical record sources to determine if a drug regimen review was conducted upon admission. And those medical record sources are the same sources that I previously mentioned. So when do you code the specific options that you have here? So you are going to code 0, no for N2001 if no clinically significant medication issues were identified during the drug regimen review. You're going to code 1, yes, if one or more clinically significant medication issues were identified during the drug regimen review. And you're going to code 9, non-applicable, if the resident was not I keep saying resident, that was yesterday, if the patient was not taking any medications at the time of the drug regimen review. This slide just shows the skip pattern. So if you code 0, no on N2001, you're going to skip to section O of the IRF-PAI manual, special treatments, procedures, and programs. If you code 1, yes, then you are issues found during the review. You are going to go on to code N2003. And if you code 9, non-applicable, the patient is not taking any medications, then you are also going to skip to section O. Now you will have the opportunity to participate in some clinical scenarios that will assist you in accurately coding these data elements. So we all slide already. So the admitting IRF nurse reviewed and compared the acute care hospital discharge medication orders and the IRF physician's admission medication orders for Mrs. W. The nurse interviewed Miss W., who confirmed the medication she was taking for her current medical conditions. Upon the nurse's request, the pharmacist reviewed and confirmed the medication orders as appropriate for the patient. As a result of this collected and communicated information, the registered nurse determined that there were no identified potential or actual clinically significant medication issues. So you are going to respond to this question: did a complete drug regimen review identify potential clinically significant medication issues? And your responses here available here are A, 0, no; B, 1, yes, issues found; C, 9, non-applicable, patient is not taking any medications; or D, a dash. And we are trending towards response A with almost 300 responses at this time. So we'll move on to the answer, and that is correct. Answer A, 0, no, no issues found during the review is correct. So in this case, you would skip to section O. The rationale for this response is that the admitting nurse reviewed and compared the patient's discharge medication records from the acute care hospital with the IRF physician's admission medication orders, collaborated with the IRF pharmacist, and interviewed the patient. And the registered nurse determined that there were no potential or actual clinically significant medication issues. The next one, Mr. C was admitted to an IRF after undergoing mitral valve replacement cardiac surgery. The acute care hospital discharge information indicated that Mr. C had a mechanical mitral heart valve and was to continue receiving anticoagulant medication. While completing the review and comparison of the patient's discharge healthcare records from the acute care hospital with the IRF physician's admission medication orders, an RN noted that the admitting physician ordered the patient's anticoagulation medication to be held if the international normalized ratio, or the INR, was below 1.0. However, the physician's admission note indicated that the desired therapeutic INR parameters for Mr. C were 2.5 to 3.5. The RN questioned the INR level listed on the admitting physician's order based on the therapeutic parameters of 2.5 to 3.5 documented in the physician's admission note. This prompted the nurse to call the physician immediately to address the issue. So for this scenario, did a complete drug regimen review identify potential clinically significant medication issues? And you have your response options: A, 0, no, no issues found; B, 1, yes, issues found during review; C, 9, non-applicable, patient is not taking any medications; or D, enter a dash. And the correct response is B, yes, issues found during the review. And the rationale for this is that the admitting nurse reviewed and compared the patient's discharge healthcare records from the acute care hospital with the IRF physician's admission medication orders. The nurse identified a discrepancy between the physician's ordered INR for this patient and the IRF's standard therapeutic range. The RN considered this to be a potential clinically significant medication issue because the admitting or physician order was to hold the anticoagulation medication for an INR of 1.0, which is below the IRF's established therapeutic INR parameters, which could lead to potential clotting issue. Next, we're going to move on to N2003 medication follow-up, which asks the provider, did the facility contact a physician or physician designee by midnight of the next calendar day and complete prescribed recommended actions in response to the identified potentially clinically significant medication issue? And your response options here are no or yes. As I've already mentioned, this item is completed if a potential or actual clinically significant medication issue was identified during the admission drug regimen review. So in other words, N2001 equals 1. The steps for addressing this second drug regimen review admission question are: to accurately code N2003, you need to determine whether two-way communication between the clinician and the physician was completed by midnight of the next calendar day, and all physician-prescribed recommended actions were completed by midnight of the next calendar day. This criteria needs to be met for all potential and actual clinically significant medication issues that were identified upon admission. You are going to code 0 no for this item if all physician or physician designee prescribed recommended actions were not completed by midnight of the next calendar day. You are going to code 1 yes if the physician was contacted and completion of the prescribed recommended actions occurred by midnight of the next calendar day after the potential clinically significant medication issue was identified. This slide shows examples of by midnight of the next calendar day. So this shows an example of when you would code 0 no for N2003. So the clinician did not communicate all identified clinically significant medication issues to the physician or physician designee until after midnight of the next calendar day. So you're going to code N2003 0 no. Another example, the clinician communicated all identified clinically significant medication issues to the physician by midnight of the next calendar day, but the clinician did not receive a response from the physician to communicate prescribed recommended actions until after midnight of the next calendar day. Then you're also going to code 0 no. And I'm just going to go through a few other coding tips. If the physician or physician designee recommends an action that will take longer than midnight of the next calendar to complete, then you would code 1 yes, should still be entered, as long as by midnight of the next calendar day, the clinician has taken the necessary measures to comply with the recommended action. In this example, the physician writes an order instructing the clinician to monitor the medication issue over the weekend and call if the problem persists. If the recommended action will take longer than midnight of the next calendar day to complete, then you can still code N2003 as 1 yes, as long as by midnight of the next calendar day, the clinician has taken the necessary measures to comply with the recommended action. If the physician or physician designee communicates that no actions are necessary regarding the reporting issues, then N2003 may also be coded 1 yes, as long as all communications took place before midnight of the next calendar day. Next, I'd just like to go over another provider question and answer that we've received. And the question is if a physician orders medications on admission and the pharmacist contacts the physician and resolves the question, potential issue, on the same day, is this still considered an issue? And the answer is if the issue was determined to be clinically significant, then the issue identified by the pharmacist and communicated to the physician and resolved by midnight of the next calendar day meets the requirements for coding N2001, yes, issues found during review, and N2003, 1, yes, medication follow-up on the admission assessment. In this question, if a facility-based physician designee performed, or physician designee performed the drug regimen review, identified a medication issue, and addressed it without needing to communicate with another physician or physician designee, how should N2001 and N2003 be coded? And the response is, in this scenario, the physician designee identified and resolved a medication issue, and therefore it did not require two-way communication with facility staff. Remember, the definition of a clinically significant medication issue requires the identification of a medication issue that warrants contacting a physician or designee, that two-way communication, in a timely manner, and addressing all physician prescribed recommended actions by midnight of the next calendar day at the latest. If no clinically significant medication issues were identified because two-way communication wasn't warranted, then N2001 would be coded 0, no, and N2003 would be skipped. The next two questions I wanted to include because they're examples of what we have determined are changes in patient conditions. So one of the questions that we've received is, if a patient complains of pain and requests Tylenol, and the nurse called the physician to receive an order, would this be a potential or actual clinically significant medication issue for the purposes of coding Section N? As described, this scenario does not meet the intent of the drug regimen review quality measure, as it appears there was a change in the patient's condition that warranted a care intervention. Therefore, providers would not be required to code it in the drug regimen review data elements. The intent of the drug regimen review data elements, to emphasize this, is to document that a drug regimen review was conducted upon the patient admission and throughout the stay, and whether clinically significant medication issues were addressed in a timely manner when identified throughout the patient's stay. The next change in condition involves oxygen therapy. So the question was, a patient was not receiving oxygen therapy on admission. During the stay, the patient's oxygen saturation level, measured by pulse oximetry, was 88%. The registered nurse notified the physician, who ordered oxygen support at 2 liters per minute. Is this considered a potential or actual clinically significant medication issue? Again, as described, this scenario does not meet the intent of the drug regimen review quality measure, as it appears there was a change in this patient's condition that warranted a care intervention or the initiation of oxygen therapy. Therefore, providers would not be required to code it in the drug regimen review data elements. Next, we're going to you'll have the opportunity to practice coding a clinical scenario for N2003. And you are going to be asked to provide responses regarding how you would code N2001 and N2003. So Mr. B was admitted to the IRF following a hip fracture and with an active diagnosis of pneumonia and atrial fibrillation. The acute care facility medication record indicated that Mr. B was on a 7-day course of antibiotics and he had 3 remaining days of his treatment plan. The IRF pharmacist reviewed the discharge records from the acute care facility and the IRF admission medication orders. The pharmacist noted that Mr. B had an order for an anticoagulant medication that required INR monitoring as well as the antibiotic. On the date of admission, the IRF pharmacist contacted the IRF physician caring for Mr. B and communicated a concern about a potential increase in the patient's INR with this combination of medications, which placed the patient at greater risk for bleeding. The IRF physician provided orders for laboratory testing so that the patient's INR levels would be monitored over the next 3 days starting that day. However, the first INR laboratory test did not occur until after midnight of the next calendar day. So first you're going to respond to how you would code N2001. So in this scenario, did a complete drug regimen review identify potential clinically significant medication issues? And your responses are A, 0, no issues found during review, B, 1, yes, issues found during review, C, 9, not applicable, patient is not taking any medications, or D, enter a dash. And we'll just give people a few minutes to continue to finish responding, and we'll move on to the response because we're at almost 300 responses. And the correct answer is B, 1, yes, issues found during review. Now I'd like you to consider what happened once the potential medication issue was identified for the purposes of coding N2003 follow-up. So did the facility contact a physician or designee by midnight of the next calendar day and complete prescribed recommended actions in response to the identified potential clinically significant medication issues? And your response options are A, 0, no, B, 1, yes, or C, enter a dash. As you're thinking about coding N2003, think about that laboratory test that I mentioned and the timeliness of that laboratory test. Okay, I need to do more work on this one. So we'll move on to the correct response. Okay, so N2003 is coded as no, and we'll go on and talk about the rationale. So a potentially clinically significant issue was identified during the DRR. The staff did contact the physician prior to midnight of the next calendar day, but did not complete, to the extent possible, the physician described actions related to the INR laboratory test and until midnight of the next calendar day. So the submission or the request for the INR was not completed or entered by midnight of the next calendar day. So that's why N2003 in this particular scenario would be coded 0, no. Okay. Anila, do I have time for one more scenario before the break? I think I do. Okay. So in this next clinical scenario, you are also going to be asked to code N2001 and N2003. Miss S was admitted to the IRF from an acute care hospital. During the admitting nurse's review of the patient's acute care facility discharge records, it was noted that Miss S had been prescribed metformin. However, admission labs indicated she had a serum creatinine of 2.4 consistent with renal insufficiency. The IRF admitting nurse contacted the IRF physician or designee to ask whether this drug would be contraindicated with the patient's current serum creatinine level. 3 hours after the patient's admission to the IRF physician provided orders to discontinue the metformin and start the patient on a short-acting sulfonylurea for ongoing diabetes management. These medication changes were implemented within the hour. So first you're going to code N2001. Did a complete drug regimen review identify potential clinically significant medication issues? You have the same response options as A, 0, no, no issues found, B, 1, yes, issues found, C, 9, not applicable, or D, enter a dash. Okay, and we will move on to the response. And the correct answer is B1, yes, issues found during review. Next, I'd like you to consider how you would code N2003. Did the facility contact a physician or designee by midnight of the next calendar day and complete prescribed recommended actions in response to the identified potential clinically significant medication issues? And as you're well informed, your response options are A, 0, no, B, 1, yes, or C, enter a dash. Okay, and we will move on to the response. And the correct response is B1, yes. To summarize this scenario, you would code both N2001 and N2003 1 yes on the admission assessment. And the rationale for this is that the physician communication occurred and the nurse completed the physician designee prescribed actions by midnight of the next calendar day. In this case, medication had been ordered that was contraindicated for the patient's current condition. The IRF clinician's two-way communication resulted in discontinuing the contraindicated medication and replacing with an appropriate medication. And Bridget, it's your call, but I'm going to move on to N2005, but I can continue or we can break and... Okay, I will do N2005 then. I wanted to have a good break, so we don't lose our train of thought. Okay, so N2005 is the medication intervention, and that is the one discharge data item. And as I've repeatedly indicated and will emphasize again, the observation period for this item is from the date of admission through discharge. And N2005 asks, did the facility contact and complete physician or physician designee prescribed recommended actions by midnight of the next calendar day each time potential or clinically significant medication issues were identified since the admission? And your coding options are 0, no, or 1, yes, or 9, not applicable. There were no potential clinically significant medication identified since admission, or the patient is not taking any medications. So the steps for completing N2005 are very similar to what you do in terms of N2001 and N2003 in terms of the documentation that you're going to review to accurately complete N2005. And you use those same medical record sources or medical sources that we talked about before, transfer note, patient histories, speaking to the patient's family, the patient themselves, validating, talking with staff from the referring hospitals, etc. The second step in assessment for accurately coding N2005 is to determine if both criteria were met for all potential and actually clinically significant medication issues that were identified upon admission or at any time throughout the patient's stay, admission through discharge. And that is the two-way communication between the clinician and the physician or physician designee was completed by midnight of the next calendar day, and all physician or physician designee prescribed recommended actions were completed by midnight of the next calendar day. Again, N2005 includes all drug regimen review information that you collected and recorded or documented and coded from when the patient was admitted throughout the patient's stay, admission through discharge. Next, we'll go over the coding instructions for how you would code each of the response options. You are going to code no, zero no, if the facility did not contact the physician and complete prescribed recommended actions by midnight of the next calendar day, each time a potential or actual clinically significant medication issue was identified since admission. And I'll give you a few examples of when you would code N2005 zero no. At admission or at any time during the patient's stay, the clinician did not communicate all identified potential or actual clinically significant medication issues to the physician until after midnight of the next calendar day. You would code N2005 zero no. At admission or at any time during the patient's stay, the clinician communicated to the physician designee, all identified potential or actual clinically significant medication issues, but the physician designee did not respond until after midnight of the next calendar day. And 2005 would be coded zero no. And in the last example, at admission or at any time during the patient's stay, the clinician did not complete all physician designee prescribed recommended actions for all identified potential or actual clinically significant medication issues by midnight of the next calendar day. You would also code N2005 zero no. An example of when you would code N2005 one would be at admission and at any time throughout the patient's stay, the clinician contacted the physician designee regarding all identified potential or actual clinically significant medication issues, and the physician designee communicated to the clinician that no actions were necessary regarding the reported issues. All communications took place before midnight of the next calendar day, so this would be a time when you could code N2005 1 as yes. You would code 9 non-applicable if there were no potential or actual clinically significant medication issues identified at admission or throughout the patient's stay, or the patient was not taking any medications at admission or at any time throughout the stay. A point of emphasis here, again, based on questions we've received from IRF providers, is that if the patient that's being discharged isn't taking medications at the time of discharge and was taking medications earlier in the stay, you would not code this data element as 9 non-applicable. So again, it's that from admission through discharge. You code N2005 based on your coding of N2001 and N2003. Again, I'll emphasize that throughout the stay includes admission through and up to the time of the patient's discharge. The drug regimen review is conducted upon admission, and clinicians complete actions recommended by a physician or physician designee during a timely follow-up, which are completed each time potential or actual clinically significant medication issues are identified throughout the stay. And timely, as I've indicated, for the drug regimen review refers to midnight of the next calendar day at the latest. One minute, okay. We'll do one provider Q&A, and then we will go to break. So this question is, if a provider coded item N2003 as 0, no, on the admission assessment indicating that the required follow-up action did not take place, is there a way for the facility to code N2005 as 1? Yes. And the answer to this is that if you code N2003 is coded as 0, no, then N2005 must also be coded 0, no. And the rationale for this is that follow-up for all identified potential or actual clinically significant medication issues was not completed by midnight of the next calendar day throughout this day. So by coding N2003 0, that means that the follow-up did not occur by midnight of the next calendar day. Even if only one medication issue, this means that if only one of multiple potential clinically significant medication issues was not followed up by midnight of the next calendar day, the facility should code N2003 admission as 0, no, and N2005 admission through discharge as 0, no. Okay, so we'll go through this coding clinical scenario so that, okay, so Bridget's saying go ahead, and do you want me to break? I know it's right a little after. Pardon?
If it's a good time to, that would be great.
Yeah, I think it's a good time to break, yeah. Okay, so we'll be back here at 10:15?
I have a couple announcements.
Oh, okay.
Thank you, Terry.
I'll just leave this here. Okay, so we'll pick up by practicing scenario number 5 regarding N2005. So at discharge from the IRF, the discharging licensed clinician reviewed Ms. T's medical records, which included admission through her entire stay at the IRF. The clinician noted that a clinically significant medication issue was documented during the admission assessment. At admission, Ms. T was taking 2 antibiotics, an antibiotic prescribed during a recent acute care hospital stay that the IRF physician had included in her IRF medication orders, and a second antibiotic prescribed by the IRF physician upon admission that is known for drug-induced nephrotoxicity. Ms. T has renal disease. Ms. T's medical records further indicated that an IRF nurse had attempted to contact the assigned IRF physician several times about this clinically significant medication issue. After midnight of the second calendar day, the IRF physician communicated to the nurse via a telephone order to administer a newly prescribed antibiotic in addition to the previously prescribed antibiotic. The nurse implemented the physician's order. Upon further review of Ms. T's medical records, the discharging nurse determined that no additional clinically significant medication issues had been recorded throughout the remainder of Ms. T's stay. And in this scenario, you're going to be asked to code N2001, N2003, and N2005. So for N2001, did a complete drug regimen review identify potential clinically significant medication issues? And your response options are A, 0, no, B, 1, yes, C, 9, non-applicable, D, enter a dash. Looks like people are trending towards answer B, 1 yes. We're almost at 300 responses, so I'll move on to the correct response. And the correct answer is B, 1 yes, issues found during review. Next, you are going to provide a response to how you would code N2003. Did the facility contact a physician or physician designee by midnight of the next calendar day and complete prescribed recommended actions in response to the identified potential clinically significant medication issues? And for N2003, as you know, your response options are A, 0, no, B, 1 yes, or C, a dash. And we can move on to the correct response. People are doing very well. The correct response is A, 0, no. Next, we'll move on to coding N2005. Did the facility contact and complete physician or physician designee prescribed recommended actions by midnight of the next calendar day each time potential clinically significant medication issues were identified since the admission? And your response options are A, 0, no, B, 1 yes, C, 9, non-applicable, or D, enter a dash. Okay, and most people have responded, so we will move on to the correct answer. And the correct answer is 0, no. So in this scenario, to summarize the coding, N2001 would be coded 1 yes, issues found during the review. N2003 would be coded 0, no. All identified potential or actual clinically significant medication issues were not addressed by midnight of the next calendar day. And N2005 would also be coded 0, no. The facility did not contact the physician or physician designee and complete prescribed recommended actions by midnight of the next calendar day each time clinically significant medication issues were identified at admission or at any time throughout the patient's stay, admission through discharge. To emphasize, coding of N2005 includes all potential or actual clinically significant medication issues identified at admission or at any time throughout the patient's stay that were or were not communicated to the physician, physician designee with prescribed recommended actions completed by midnight of the next calendar day. Although no potential or actual clinically significant medication issues were identified by the nurse during the remainder of the stay, notification of the medication issue identified at admission, despite repeated communication attempts by the nurse, was not addressed by the physician or physician designee by midnight of the next calendar day. Next, we'll go to the final scenario for today's presentation. At discharge, the licensed clinician completing a review of Mrs. K's medical records identified and noted 2 clinically significant medication issues during the patient's stay. The patient's record included an order to hold the medication Ms. K was receiving for deep vein thrombosis prophylaxis for a scheduled procedure. The RN noted that this medication had not been restarted 48 hours post-procedure and determined that the physician needed urgent notification. The day after the notification occurred, the IRF physician provided an order to resume the medication, which was carried out by the nursing staff within the hour. In addition, a licensed clinician identified a clinically significant medication issue had occurred during the admission assessment period, and the physician had been contacted on the same day. Both medication issues identified during the patient's stay were communicated and addressed by midnight of the next calendar day. There were no additional clinically significant medication issues identified during the remainder of the IRF stay. Again, you're going to be asked to how you would code N2001, N2003, and N2005. So for this scenario, for encoding and purposes of coding N2001, did a complete drug regimen review identify potential clinically significant medication issues? And your response options are A, 0, no issues found during the review, 1, yes, B, 1, yes, issues found during the review, C, 9, not applicable, patient is not taking any medications, or D, enter a dash. And we'll move on to the correct response because it looks like people have had time to respond. And yes, the B, 1, yes, issues found during the review is the correct response. Next, I'd like you to think about how you would code N2003. So for this scenario, did the facility contact a physician or physician designee by midnight of the next calendar day and complete prescribed recommended actions in response to the identified potential clinically significant medication issues? And your response options are A, 0, no, B, 1, yes, or C, enter a dash. And we'll move on to the correct response. And B, 1, yes, is the correct response, which the majority of you responded accurately. In this case, both medication issues identified during Mrs. K's stay were communicated to the physician and resolved by midnight of the next calendar day after identification. And last, how would you code N2005? Did the facility contact and complete physician or physician designee prescribed recommended actions by midnight of the next calendar day each time potential clinically significant medication issues were identified since the admission? And your response options are A, 0, no, B, 1, yes, C, 9, not applicable, or D, enter a dash. We're trending towards B1, yes. And we'll move on to the correct response. And B1, yes, is the correct response. So to summarize this scenario, N2001 would be coded 1, yes, issues found during the review. N2003, 1, yes, would also be coded yes, because the two-way communication and completion of the prescribed recommended actions occurred by midnight of the next calendar day after the potential clinically significant medication issue was identified. And N2005 would also be coded 1, yes, because the facility contacted the physician and completed prescribed recommended actions by midnight of the next calendar day each time clinically significant medication issues were identified at admission or at any time throughout the patient's stay, admission through discharge. Although a medication error was identified as a clinically significant medication issue at admission, it was resolved by midnight of the next calendar day. Further, the drug regimen review conducted at discharge included the entire patient's stay, admission through discharge. During the patient's stay, a second clinically significant medication issue was identified. Each time the clinically significant medication issues were identified at admission and during the stay, they were communicated to the physician and resolved through completion of prescribed recommended actions by midnight of the next calendar day. Next, we'll move on to a discussion of the drug regimen review conducted with follow-up for identified issues quality measure. The drug regimen review conducted with follow-up for identified issue reports the percentage of patient stays in which a drug regimen review was conducted at the time of admission and timely follow-up with the physician or physician designee occurred each time potential and actual clinically significant medication issues were identified throughout the patient's stay. A patient's stay is the period of time between a patient's admission date into an inpatient rehab facility and the date of discharge. As previously described, timely for the drug regimen review refers to midnight of the next calendar day at the latest. I'm going to walk through this slide as it contains a lot of information. The drug regimen review quality measure is a process quality measure that is calculated as a facility level observed score. To calculate the percentage of patients that successfully met the drug regimen review measure criteria, we set up a fraction. And the fraction is comprised of the numerator and the denominator. The denominator for the drug regimen review measure is the number of patient stays in the selected time window. The numerator is the upper part of the fraction used to calculate a rate and is a subset of patients in the denominator. For the drug regimen review measure, the numerator includes patient stays in the denominator in which the total number of stays in the denominator meeting each of the following two criteria. The first criteria is the facility conducted a drug regimen review on admission, which resulted in one of the three following scenarios. The first scenario is no potential and actual clinically significant medication issues were found during the review, or in other words, N 2001 equals 0. Or the second scenario, potential and actual clinically significant medication issues were found during the review, N 2001 equals 1, and then a physician or physician designee was contacted and prescribed recommended actions were completed by midnight of the next calendar day, or in other words, N 2003 equals 1. Or in the last scenario, the resident was not taking any medications, and 2001 equals 9. The second criteria is that appropriate follow-up occurred each time a potential or actual clinically significant medication issue was identified during the stay, or N 2005 equals 1, or no potential or actual clinically significant medication issues were identified since the admission, or the patient was not taking any medications, and 2005 equals 9. So then to calculate the facility level observed score, you divide the facility's numerator count by its denominator count to obtain the facility level observed score. And then you multiply by 100 to obtain a percent value. As I've mentioned, the drug regimen review quality measure is a process measure, and therefore it is not risk adjusted nor stratified. And for the IRF setting, there are no denominator exclusions. This slide just summarizes or reviews what I already went through in terms of which data elements are included in the calculation of the quality measure. And as you can see here, it's N2001, the drug regimen review, N2003, the medication follow-up, and N2005, medication intervention. In summary of this presentation, the drug regimen review is an assessment-based, cross-setting process quality measure adopted to meet the requirements of the IMPACT Act domain of medication reconciliation. The DRR measure includes the following items, which we have reviewed throughout this presentation. The measure assesses whether a drug regimen review was conducted upon the patient's admission and throughout the patient's stay, and whether any potential or clinically significant medication issues identified were addressed in a timely manner. And as you've been collecting data on this particular measure, Encoding, since October, I suspect that many of you already have your action plans in place. As Bridget mentioned at the beginning of the session today, certainly feel free to share your action plans and ideas with each other. And at this time, because we have some time, I will open it up for questions from the audience. We have received several DRR questions already, so I'll be looking at those at lunchtime. But if anyone would like to ask a question at this time, I would welcome it.
Trying not to be picky, but on slide 93, I think you have a typo.
On slide 93? Well, that's good to know for future training.
In the top orange box, it says patient will be kept in the denominator. I think it should say the patient will be kept in the numerator, right?
I actually can't see it because the print is so small, so. Okay, well, I'll take a look at it and correct it if it's a typo.
Another question?
Is there a question over here? Bridget will come over.
On slide 47, can you hear me?
Barely.
On slide 47, in your example, you mentioned that if a physician identifies an issue and addresses the issue without communicating with another physician, you say to code N2001 as you know.
Mm-hmm.
However, in your manual, your IRF-PAI training manual, for section or item N2001, it doesn't say anything about communication or lack thereof. It only mentions that if there was an issue identified. So can you please clarify the rationale for coding that as no?
Sure. Let me just think this through for a second, because this is a question that's come in as we subsequently have developed the text that's in the manual. So what's important for this measure is that you're not going to code. Let me say this a different way. So what's important for coding these data elements is the two-way communication that occurs. So if I'm the registered nurse and I think that there's an issue that requires immediate attention to that particular medication issue, then I'm going to, and I think I should contact a physician to get some guidance on how we should handle this medication issue. That's the crux of when the data elements for drug regimen review apply. In this particular scenario, the physician essentially is taking care of something that they have identified or noticed, and it's not requiring communication with another provider. So that physician doesn't feel like, oh, I'm just going to, the physician interprets this, I can take care of this issue. It's not something that I feel that I need to communicate to the nurse. I've just taken care of it.
So does that include pharmacists as well? So our facility protocol is that if our pharmacist identifies an issue, they update the medical record. So if the pharmacist does that without two-way communication, is that also a no?
What do you mean by updates the medical record? I just want to be clear, I don't mean to be.
So if there's like duplicate orders for medications, like a generic and a brand name, our pharmacist will take that off of the medication list.
Okay. Do they do that independently? They do. Then I would say that that does not constitute the intent of the drug regimen review, because if they've taken an action independently, did they communicate with anybody in that situation? Then I would say that it would not apply.
Well, I mean, when you update the medication list, you're communicating to the entire team the update. Like you're not doing it verbally, but it is in the medication list. So you technically are communicating that to the whole team.
I'd like to think about that one a little bit more and get back to you, because I consult with my colleagues too, because one of the things that we're really trying to do with all of our measures and coding is to be aligned across settings. So IRF, LTAC, SNF, home health. So I'd like to talk with some of my colleagues about that. So you're saying that the communication, it's not a verbal communication, but it's been communicated through, like, through the EMR? Yeah.
Like when you update the medication list, that's in the patient's chart. And so anyone who can see the medication list is being communicated that this is the new medication regime. So even though it's not a text or a phone call or face-to-face, you're putting words into the patient's chart saying this is the medications they receive at this time in this manner.
And is this occurring like on admission, or is this occurring throughout the stay, or when is it?
The pharmacists do the drug regimen review on admit, and so they will update the medication list on admit.
Okay. So the issue then is this appropriate communication? And then if that is appropriate communication, then does that meet the intent of the DRR? That's what your question is. Okay.
Any other questions? Okay. I'll be.
Well, thank you very much. I appreciate all the questions that we get, because, as I said, I've been learning a lot too, and this is a good example of real live scenarios that are happening in your organizations, and we want to be able to help you so that you can accurately code. We also don't want to increase your burden of coding by having situations where the drug regimen review, it's not the intent of the drug regimen review. So thank you very much. Appreciate it.